Perfect. Thank you. Alrighty, everyone. I'm going to go ahead and mute everyone's lines before we get started. And Michelle, you will have to press #6 to unmute yourself. So bear with us just 1 second.
The leader has muted your line. To unmute your line, press #6.
Good afternoon, everyone. This is Giuliano, the Med Safety and ADE Regional Lead for the New England QIN-QIO, and thank you for joining us for today's webinar entitled Breaking the Back of the Beast, Improving Outcomes in Chronic Pain Management Through Commonsensical Opioid Use. Before we get started, I'm going to quickly review a few housekeeping items. This call will be recorded for training purposes. The recorded presentation will be available within a few business days after the webinar on our website. The phone lines will be on mute for the duration of the presentation. We will take questions at the end, and I'll provide you with instructions on how to ask questions at that time. Although the lines will be muted, we want you to actively participate in this session. You'll have an opportunity to weigh in via chat. My colleague, Colleen Cordano, the Medication Safety Lead in Massachusetts, will be monitoring and responding to chat during the session. We'd love to learn more about your efforts on managing patients on opioids and how we can best support your efforts going forward. It's important to note that today's speakers have no conflict of interest to disclose. Our speaker today is Michele Matthews. She's a PharmD and an Associate Professor of Pharmacy Practice at Mass College of Pharmacy. She's an advanced practice pharmacist in pain management at Brigham and Women's Hospital. As I shared during this call, we want to use the chat feature to get to hear from you and what you're doing and what we might be able to assist you with. So let's start by just seeing who's on the call. Please type in your name, your organization, the state that you're in, and if you have any questions or comments during the presentation, please enter them into chat. At this time, I'll turn this over to Michele Matthews. Thanks, Michele.
Thanks so much, Margie. Hi, everyone. Good afternoon. Thank you so much for taking time out of your busy day to join us. I am just waiting to be turned over as a presenter, and it looks like that has just happened. So we're going to get started with moving into today's presentation. Some of the learning objectives that we'll cover over the next 30 minutes or so are to discuss some of the factors that have been contributing to opioid overdoses and other opioid-related adverse effects. I'm going to review some best practices for initiating, monitoring, and discontinuing opioid therapy for chronic pain, particularly in the context of the Cdc Opioid Prescribing Guidelines. And then at the end, identify models of care quality metrics that can promote the safe and effective use of these medications, more so in the outpatient setting. So before we dive into a discussion about opioid use in chronic pain, I think it's first important to start with the basics and provide you with somewhat of an understanding of what we mean when we say chronic pain. Over the past couple of years, as providers, we've started to recognize pain more so as a chronic disease, and we understand that this is something that is going on in a patient for more than about 3 to 6 months and extends beyond the acute initial injury that the patient has, and also has a significant adverse impact on the patient's function and well-being. So what we understand about what happens in patients that have chronic pain is that there is this sensitization that occurs within the central nervous system where everything is hyperactive. It's almost like there's a nightclub that's happening in someone's brain. Constant noise, it's very loud, and as time goes on, pain itself could actually make pain worse. So we call that wind-up, we call that central sensitization, and not only does it cause the patient to have poor outcomes, it makes it really challenging to treat as time goes on. And we're just talking about the pathophysiology of pain. We're not talking about all of the collateral damage that happens when somebody has pain. That includes some of the emotional distress, psychological issues, and other psychosocial issues that present itself as part of this chronic disease picture.
Hey, Michele, this is Morgan.
Yeah.
Is there any way you can speak up a little bit? People that are having trouble hearing you.
Oh, sure. I'm sorry. Is that better?
A little bit.
Okay. I'm as close to my phone as I possibly could be.
That's better. Excellent. Thank you.
Okay. Yeah, no problem. Sorry about that. So as we think about where analgesics fit into the management of chronic pain, there are several considerations, including understanding the diagnosis, how long the patient has been in pain, thinking about the age of the patient because there are age-related changes that affect medication response, thinking about comorbidities, drug interactions, especially thinking about opioids and how they may interact with central nervous system depressants like sedative hypnotics or benzodiazepines. But then we also have to think about the complexity of the regimen and the health literacy of the patient. All of these things, if considered at the beginning of treatment, may help with ensuring successful use of the medication and minimizing some of those adverse effects, especially for considering a high-risk medication. So we think about the evidence that we understand related to the use of opioids for chronic pain. The evidence is minimal and not overwhelming. There's only fair evidence for the short-term use, so no more than 3 months in patients with chronic pain. That has led to somewhat of an improvement in the pain score or pain severity, as well as quality of life. There's very minimal evidence out there to discuss returning to work productivity, improvement of activities of daily living, and those are really the important outcomes that we pay attention to in the setting of chronic pain. There's also very weak evidence to support utilizing extended release versus short-acting opioids for chronic pain. And many times we end up making that decision based on several patient-specific factors. And then that also gets into if a patient is on opioid therapy and they're switched to another opioid, there's very limited evidence to suggest that there will be successful outcomes when that happens. So we're in a difficult position kind of thinking about just focusing on evidence and where opioids fit in to the management of chronic pain. And that's where, in most cases, we do end up paying special attention to the patient as we make those decisions. So before we go into some of those guidelines that can help us with choosing the right patient and then also monitoring these medications, I think it's helpful to talk about how we ended up being in this space of having opioids at the center of a public health crisis. Back in the early 1980s, the World Health Organization created the ladder for pain treatment that was specifically created for patients that were dealing with cancer-related pain. It was also at that time that the first controlled-release opioid, morphine, became available on the market. And not shortly after that did we have the medical community that was advocating for expanding the role of opioids for all types of pain management, chronic non-cancer pain, chronic cancer pain. In 1996, there was more availability of some of these controlled-release medications, specifically the first formulation of OxyContin. And at that time, the American Pain Society was beginning to urge the medical community to consider pain as a vital sign. At the end of the 1990s decade, we had the Veterans Administration and the Joint Commission adopt pain as the fifth vital sign. And over that period of time, there was a significant increase in opioid prescribing, also an increase in opioid-related adverse events and deaths. And now, as of 2008, opioid-related overdoses surpassed auto fatalities in most states as the leading cause of accidental death in the United States. So that is just one piece of the picture. That absolutely does not explain how we ended up where we are. But there are several things that have happened and I think fortunately have changed, particularly over the past couple of years as we've had more guidelines and more regulatory changes related to the use of these medications. But there have been a lot of prescriber, patient-related, and system-related factors that have contributed to adverse events. Some of the prescriber-related issues have been related to lack of knowledge and understanding related to pain and the medications utilized, lack of support, not having the right transdisciplinary team in place to care for a resource-intensive population. From a patient perspective, the appeal of having immediate release and being in a society of having access to instant gratification, and then focusing more so on pain severity rather than some of the functional and well-being outcomes, which we now realize are the more important targets when we manage this population. From a society and a system perspective, there is an understanding that there should be an acceptance of right to pain treatment, and for a long period of time that was equated to opioid therapy and having access to those medications. And interestingly, up until the past couple of years, it was actually easier to have insurance coverage of certain opioid medications than it was towards adjuvant analgesics, such as anticonvulsants and antidepressants, and that has significantly changed over the past couple of years as well. So all of these things have culminated into where we end up today in terms of our decision-making related to the utilization of opioids. So I'd like to present to you an actual patient case. This is actually very common to the type of patient that I would see in one of my practices, which is through Brigham and Women's Hospital's primary care center. So this is a patient that was referred to me by the PCP, who at this visit was seeing the patient for the first time. He was a 37-year-old man with a history of chronic left arm pain that was related to a motor vehicle rollover crash that ended up causing a severe avulsion injury, so it's a degloving injury. And he was presenting for a new primary care appointment and had previously been managed by a provider who decided that that person was no longer going to prescribe opioids. And we're seeing a huge increase in these referrals to us where providers are no longer feeling comfortable and are referring the patients out to other specialty offices and even other primary care practices. Per the patient's past medical records, it was identified that even though the patient was getting monthly prescriptions of opioids, there had not been a reevaluation of the patient's pain in almost a year. As we moved forward with our history of present illness and our pain history with this patient, the onset happened after the motor vehicle accident. The patient reported that the current medications, which I'll go through in a minute, were only providing about 10% relief of the pain, and that any movement of the arm was associated with significant pain. This patient described the pain as burning, gnawing, sharp, and stabbing that radiated from his left forearm to his fingers. The pain was rated as 20 out of 10. We hear that very commonly, that the 0 to 10 scale doesn't always fit the patient's perception of the pain severity. The pain was worse in the morning, somewhat manageable during the day, and then got worse again at night, likely due to the activity that he was trying to do during the day. And then the impact that the pain was having on the patient was that he was unable to sleep and had a very difficult time completing activities of daily living. So as we move into his past medical history, we identify that he had a history of post-traumatic stress disorder. He is a Iraqi war veteran and also had a history of depression. At the time that we were seeing this patient, he did not have active psychiatric care and was also refusing consideration for treatment with an antidepressant. Also had a past surgical history of amputation of the left thumb, which was a result of the motor vehicle accident, and then also a left wrist fusion that also required a bone graft. So we're dealing with a patient with a pretty significant injury, but also we've identified that there might be some risk factors that indicate that he might be at risk for misusing his medication. Looking at his allergy profile, there was nothing concerning related to past bad reactions to medication. Current medication list, oxycodone immediate release, 30 milligram tablets, you can see the interval there, as well as OxyContin 15 milligrams by mouth every 8 hours. He was taking levofloxacin and Bactrim to help with preventing infection due to the surgeries that he had on his wrist. As the Docusate and the Senna were added to help with managing opioid-induced constipation, and then gabapentin was a medication that he had just started recently prior to this current visit. And what I want to point out here specifically with the oxycodone and the OxyContin is that this regimen kind of just stands out as not really making a lot of sense. It's not common for us to see the dose of the longer-acting opioid to be lower than the dose of the shorter-acting medication. And I think that's an opportunity for us to reevaluate, especially as pharmacists, to say, this maybe doesn't make a lot of sense. If I put my risk management hat on and think about abuse potential and diversion potential, Oxycodone immediate release 30 milligram tablets have a high demand on the streets. So I have to think about that as well as we move forward with making our decisions. So to me, this medication regimen, although there is a combination of opioids with adjuvant analgesics, in this case would be the gabapentin, it doesn't really make too much sense in terms of it being appropriate use of opioids. With regard to the patient's family history, there was a family history of alcohol use disorder, so there is this genetic link related to addictions that we have to consider. And then from a social standpoint, patient's a current smoker. We do know that smoking can actually exacerbate chronic pain. There is some alcohol use that happens during the football season, so that's active drinking at this moment. There has been a history of daily marijuana use, denies other substances, but does have a history of heroin use. Currently unemployed, lives at home with his girlfriend and his 2 dogs. From an opioid risk assessment standpoint, reviewing the MassPad, our Massachusetts Prescription Monitoring Program, tells us that the patient has been receiving the same prescriptions from the former PCP with no early refills over the past 9 months. The SOAP score, which is the screener and opioid assessment in pain patients revised, is a trait measure that gives us an indication on the patient's risk level for misusing the medication. And misuse in this case would mean taking the medication in any way other than prescribed, which could potentially lead to abuse and addiction. So at baseline, he's identified as being a high-risk patient. However, we're also implementing a tool that helps us identify if there's active misuse that the patient's reporting. And we do that through the current opioid misuse measure. And through that evaluation, that tells us about the patient's medication use over the past 30 days. And there were no behaviors reported through that measure that indicated to us that he was actively misusing his medication. The addiction behavior checklist was 0, indicating no aberrant drug-related behaviors. His PHQ-9 score was high, indicating that there is severe depression. And his urine drug test results did come back positive for oxycodone and oxymorphone, which is appropriate in somebody that takes OxyContin and oxycodone. Also positive for THC, which he is admitted to smoking marijuana on a daily basis. So in a patient where you have a significant injury, unlike in some cases where we have these chronic musculoskeletal pain disorders like chronic low back pain, where it may be very hard to identify the true source and imaging may not be very clear in elucidating why the patient's report of pain is different than our understanding of what's happening with that pain, we have a legitimate injury. But we also have a patient that has been identified as being high risk. So the guidance that we have had up until recently has been, well, we know that there's not a lot of evidence, but I feel that this patient really could benefit from these medications. But what are all the steps that I have to take to ensure that these medications are started in the right patient, monitored appropriately, and then when things go bad, how do we make a decision to end therapy or ensure that the patient has access to treatment that they need thereafter? So the Cdc Guidelines were developed. They were published in March of 2016, and they were intended for primary care practitioners, and they are geared towards the patient with chronic pain outside of the realm of palliative and end-of-life care. So we're talking about patients with chronic non-cancer pain, cancer survivors who may have chronic pain that has happened as a result of chemotherapy or as a result of surgeries, although they may be in remission. So this guideline is intended to cover the following topics: determining when to start or continue. So in this case of the patient, we have to make a decision about whether or not it's appropriate to continue. We have to think about which opioids we have available to us, the dosage, duration, how we follow up, and then how do we stop them, which can be very challenging. And then also thinking about how we assess risk and address harm with these medications. I do want to point out the evidence that has been utilized to develop these guidelines. So as someone like myself who's been working in pain management for several years, I'm pretty up to date with a lot of the literature, and I think it's important to note that there really hasn't been anything groundbreaking in terms of being favorable for using opioids across the board for chronic pain. However, these guidelines were put together more so thinking about the fact that evidence is limited, and the majority of the data is being pulled to support this guideline from randomized controlled trials that have significant limitations in their methodology, as well as observational studies, along with clinical experience and anecdotal experience. So that is really one caveat that I do want to point out about interpreting and utilizing these guidelines. So I'm going to go through the guideline in order, starting from the beginning and kind of talking about, there's a reason that this was the #1 guideline related to the use of non-pharmacologic and non-opioid therapy. I think for any patient that is being evaluated for chronic pain, this has to be the starting point. Opioids really should always be considered towards the end. So if we think about our patient in that pain history, I didn't really give you a lot of information about what he's tried before, medication, complementary and alternative medicine strategies, things that may have potentially been beneficial, that maybe because of the type of injury were overlooked or maybe deemed inappropriate. For any patient, this is a starting point. This is where we have to consider what's available to the patient. Not all of these non-pharmacologic approaches that we often talk about in chronic pain are available. Many times they can be very expensive. They're not covered by insurance very often, and in certain situations they may not be effective for the type of pain that the patient has. But they have to be considered, and I think in most cases, if opioids are going to be utilized, they really should never be prescribed alone. So the approach to chronic pain is multimodal. Analgesics, non-pharmacologic therapy, behavioral intervention, so those are all things that are used to support a patient. And you note from the patient case that although opioids were on board with gabapentin, there was a decline by the patient to move forward with psychiatric services. There was no other support that was being provided to the patient at the time, and that could potentially increase the risk of adverse outcomes with the use of this medication. Moving on to thinking about where opioids fit into treatment goals. We always have to think about balancing the risk and benefit in anything that we do. And I think it's important in chronic pain to not just focus on the pain score. I find that very often I'm spending more time discussing what the patient-specific functional outcomes are. Return to work, be able to get out of bed on their own, be able to feed themselves, be able to do grocery shopping and make the bed on their own, versus asking about the pain score, because I find that, and many others will agree, that number doesn't change. It's a very patient-specific and subjective number, and it's really hard to tie treatment just to that outcome alone. So the pain score does not tell the whole story. Each patient should be evaluated based on the achievement of those goals that are important to them, and if the pain's not improving with the use of an opioid, it's at that time that opioids should be reevaluated. So one of the best things to consider integrating into goal setting and chronic pain management would be using SMART goals. These are used very often in motivational interviewing and health coaching, and it allows us to develop specific, measurable, attainable, realistic, and timely goals that are tailored to the patient. Some of the sample outcome measures that can be utilized for chronic pain are the brief pain inventory. These are all multidimensional pain tools that ask questions that extend beyond the severity of the pain. So everything on the left-hand side can be integrated into all types of chronic pain. The questionnaires on the right-hand side may be specific to certain pain disorders like fibromyalgia and neuropathic pain. If we think about risk management strategies and what we should be evaluating in patients prior to starting treatment, there are certain risk assessment tools that will help us identify if the patient is at high risk or low risk or maybe somewhere in between from misusing their medication. Our practice has utilized the SOAP, but there's also the opioid risk tool, the DIAR. These can be used interchangeably. Urine drug screens are recommended to be utilized at the beginning of treatment, before treatment is started, preferably, so that what's discussed during the initial encounter can be matched up to what is actually included in that urine drug test to ensure that there's no discrepancies of patient report of use of substances, and then also to screen for illicit drug use. And then the prescription monitoring program, I think in many cases, many states have implemented requirements related to this, but in the states that there are no requirements, it's important that that's a part of your evaluation. So all of that can be done before opioids are started. We can risk stratify our patients and identify who do we have to see more often, who are these patients that maybe need to be seen less often, and ramp up or ramp down that monitoring based on that. And then for periodic risk assessment, we have tools such as the current opioid misuse measure that will give us a snapshot of medication use over the past 30 days to tell us if there's any behaviors that might be concerning, periodic urine drug screens, as well as use of the prescription monitoring program. Moving on to the next guideline, it is recommended that we spend time talking with patients about risks and benefits of opioid therapy. And I think this is really where we're missing the mark in a lot of cases. I asked this question to my students yesterday, and I said, if you were talking to a patient about opioids, what would you want them to know? And one of the students responded with, do they even want to be on an opioid? So I think sometimes we have to go back to the beginning and say, what do you understand about being in chronic pain? What do you understand about where these medications fit in? And we can talk about, okay, if we start these medications, these are the common side effects that we expect to see. But many times these patients are placed on long-term therapy, and we have to think about the long-term impact. So we call this in many cases being between the devil and the deep blue sea, because everything on the left is what we're looking for, the improvement in pain and quality of life, patient satisfaction with the care we're providing with them. But everything on the right are things that we expect to see, and then unfortunately unexpected adverse effects that can have pretty significant consequences, especially addiction, hyperalgesia, where the pain ends up becoming worse over time, which could potentially be caused by the opioids. If we do decide to move forward with continuing opioids or initiating opioids in an opioid-naive patient, there is a recommendation from the CDC to consider prescribing immediate-release opioids instead of extended-release opioids. And I agree with that just for the sheer principle of thinking about pharmacokinetics of medication. In any situation where we're starting a medication, if we start something that doesn't last very long and the patient has a bad reaction to it, it's easier to reverse the effects of that medication than locking them into a fentanyl patch or a methadone dose. So I think this makes sense. It gives the patient experience with the medication. If they tolerate it and it provides them with pain relief, then there's an opportunity to transition them to an extended release or a long-acting formulation if that's available. But at the end of the day, if you have a patient that has intermittent chronic pain, it doesn't make sense to prescribe them an extended release or a long-acting opioid. So think about the patient, and there's no evidence to state that one formulation is better than the other. If we are utilizing opioids, we're thinking about the dosage that is being prescribed. So we know that if dose level is higher than 100, 120, even 200 milligrams of morphine equivalent per day, the risk of an overdose can increase significantly, and that is increased thereafter in a patient with psychiatric disorders, in a patient that may also be abusing other substances that are CNS depressants, particularly benzodiazepines. So we do have to think about the dose levels here. I know that there have been regulatory changes in some states where there's actually mandates where patients have to be referred to pain clinics if they're on more than 120 milligrams of morphine equivalent per day. And I think these numbers can sometimes become tricky because the calculation to get to that point varies depending upon which numbers are used. But I do think we have to pay attention, again, similar to the last guideline, that not all patients are the same. There are pharmacogenetic differences related to opioid receptors and analgesic metabolism. So although we pay attention to those dose levels because the higher we go, the more likely there is to be side effects, but not everybody's the same. So let's not try to fit the square peg into the round hole. But if those patients need to be on higher doses, we do need to be clear in our justification to not only to the patient, but then also in our documentation as to why that's the case. So these are just a select few reasons why patients are different in their response to medication. There's differences in response to pain as well as medications related to gender, genetics, pharmacokinetics, drug metabolism, age-related changes, organ decline, changes in the skin if medications are being given transdermally, and then also health literacy, patients' understanding of where these medications fit in and how they should be used. Moving on to the next guideline, we have thinking about where opioids fit into the acute pain management. This has been something that has been, I think, integrated into several states' legislative changes. I know here in Massachusetts that's been the case as well, where there's a limit on prescribing no more than 7 days worth of opioids for acute pain. But this kind of gets back to the last guideline. Not everybody's the same. So we do have to think about the patient. So we do have to be mindful of the laws related to prescribing, but we also, at the end of the day, should be advocating for sufficient pain relief in those patients that need it, especially because we know that there are models for surgery and other types of acute pain situations that could lead to acute pain that have resulted in maybe 30 to 50% of the increase in the likelihood of developing chronic pain. So getting acute pain under control and doing a really good job of that could prevent somebody from transitioning into that chronic pain state. Guideline number 7 talks about thinking about when to escalate therapy in patients and not doing it very quickly, and then ensuring that therapy is consistently reevaluated. And the best way to follow through on doing this are to assess the 8 A's at every visit. This is a practice that I've adopted. This was something I don't take credit for, but it was created by a pain physician several years ago. And he initially talked about the 4 A's, which are basically the first 4 things on this list. And over time, we've realized that we've had to add other things that have to be evaluated. Analgesia, adverse effects, activities of daily living, and aberrant drug-related behaviors are things that we've consistently evaluated. But from my perspective, especially as a pharmacist, I have to pay attention to the impact of being on these medications. Is the patient taking them correctly? Do they have access to treatment? So we're seeing more insurance restrictions. We are going to see limitations in manufacturing as of this year, which is now a requirement by the DEA, and then use of adjuvant analgesics. So there's thinking about not just the impact the opioid will have directly on the pain severity and the activities of daily living, but thinking about all the other things that go around with being on an opioid. And to be honest with you, some of these things, like access to treatment, could actually be something that causes more stress and pain, emotional pain, for patients than the opioid itself. So just some food for thought in terms of what should be considered over time. When we've done this assessment and we've identified that we have to make a decision about continuing or not continuing, there's some things that should help in supporting when to stop opioids. So if we're prescribing and the patient's not having any significant reduction in their pain, that's accompanied by a lack of improvement in function, there's adverse events, the patient is persistently non-experienced. That could mean skipping doses, early refills, taking double the dose than what they're supposed to take, and then worsening pain because there is a concern for opioid-induced hyperalgesia. These are all reasons for us to feel supported in communicating to the patient that we feel that the harm is outweighing the benefit. The next guideline does also fall in line to what we were talking about related to thinking about the dose level of the opioid because there are dose-related adverse effects. So we need to do what we can in a patient where we feel opioids are necessary to minimize the risk as much as possible. So one of the ways that we can do that is through better patient selection, so making sure that we're starting these medications in the right patient, that we're providing them with the right education, and increasing our availability of naloxone. So in Massachusetts, we have access to naloxone through several different avenues. So anybody can walk into a community pharmacy and ask and request Narcan or naloxone without a prescription. And I believe several other states that's the case as well. So I do want to just highlight some of the risk factors other than what was included in the guideline. Maybe some things that we don't always pay attention to. So everything on the left-hand side, I think, is pretty straightforward and consistent to what I've already mentioned. But the stuff on the right that I think we have to think about, too, is are we dealing with patients that don't have access to emergency medical services, so some of our more remote patients, household members that might be around people that are in possession of opioids, and then the psychological factors that are sometimes involved with opioid use, like catastrophizing and impulsivity and chemical coping, because all of those behaviors can increase the likelihood of misuse and abuse. There are several different naloxone formulations that I've listed them there for you. These can be prescribed in Massachusetts. They can also be prescribed not only to the patient, but also a family member, caregiver, or a friend. Other states have laws that allow anybody to go into a pharmacy to purchase these prescriptions. And the availability has kind of varied. Sometimes they're out of stock, other times they're not. And then as you can see here, Evzio, which is an intramuscular formulation, the price of that formulation has increased significantly. So I right now have had most success with utilizing the intranasal naloxone formulation through the use of a mucosal atomizer device. And I think when we're educating patients about what role this plays, it can be challenging because I think some patients feel that there's an assumption that if we're bringing up naloxone, that means that we're concerned that they've become addicted or are abusing their medication. But I like to liken it to having a fire extinguisher at home, something protective, but the patient, we need to provide education beyond the patient. There are other people that are around that patient, friends, family members, that should be aware that the patient has access to something like this, so it actually could be used to save that person's life. If we move on to the next guideline, this is specifically related to the prescription monitoring program, so this will help us identify any concerning prescription patterns that have happened as time goes on. It is a very valuable tool. Although ours has changed here in Massachusetts and it has gotten better and it is much more timely, there are still limitations. But it is a tool that we have available to us, and we should be using it on a regular basis. Some things to be on the lookout for, especially for those of you that are working in community pharmacies. You're probably very familiar with this list, but I think it's a good reminder, especially because not all states have implemented electronic prescribing. I think New York State right now is the only state that's doing that pretty regularly, and I think eventually we'll move there. But until we can, forged prescriptions originating from outside immediate geographic areas, cash payments, early refills, etc. So some of this stuff can be identified through the prescription monitoring program. Other things would be identified at the level of the pharmacy, and hopefully there's good communication back to the prescriber if they're identifying anything concerning. Moving on to the next guideline, talks specifically about urine drug tests. This is a tool that we've used in practice for many years. And we find it to be very valuable. The problem with it is that it is not a fail-safe tool. So they're helpful at the beginning of therapy to basically support what information the patient provides you. So as you talk about social history and the patient denies illicit substance abuse, if a urine drug test is done at that visit and it comes back negative, you can feel confident that there's no illicit drug use that's happening at that time. Many practices utilize urine drug tests with every prescription. So there is this thought that patients are planning for the test, and that's one way that the results can be tampered with, per se. And I've seen a lot of really interesting things that patients have done to tamper with their urine samples. I think they're best done on a regular basis, but not on a scheduled basis. If random urine drug tests can be done, that is preferred. And I think it's also important to make sure that you understand how to interpret the urine drug test. Our urine drug tests are very comprehensive. They include a lot of metabolites. So if I was a provider and a prescriber not comfortable with understanding how these medications are broken down, I'd probably want to have that information before I decide to continue treatment or discontinue treatment based on that information. But there does not seem to be consensus on the frequency of how this tool should be implemented. So we really should, at the end of the day, think about our risk stratification and patient-specific factors. This next guideline to me seems to be common sense, and this gets back to the title of the presentation. If we combine opioids with any CNS depressant, that can increase the risk of an adverse event. But it has been identified that specifically with benzodiazepine, that the risk of an overdose can increase the risk of death, that an overdose death can be increased by almost threefold. So that right there to me is justification that we probably shouldn't be using benzodiazepines in combination. I understand that there are caveats to that. There are patients that are monitored and are doing fine with that. But there should be an evaluation and consideration for alternative types of anxiety management, sleep management in these patients. And moving on to the last guideline, this was specifically added into the guideline to ensure that we're considering that in those patients where we're doing this routine monitoring and they begin to identify the development of an opioid use disorder, that we know how to screen for that and ensure that the patient gets into the right treatment. So close monitoring can help identify any of those behaviors that might be suggestive of opioid use disorder. And I think as any clinician that is working in direct patient care, that we should all be educated or possibly even certified in how to screen, provide a brief intervention, and also a referral to treatment. We call that expert. So if we think about having all of that information given to us through the Cdc Guidelines, I think it paints a clear picture about what to do and how to move forward with this patient. So I think we have a patient that has a significant injury. It's a patient that we've identified as being high risk for misusing the medication. But I think there's probably some modifications that are necessary to make to the medication regimen before I know I would feel comfortable moving forward with continuing to prescribe. So I think that the prescriber can feel supported in using some of the information in this guideline to perform a urine drug test at the time of meeting the patient, maybe providing a limited supply of medication or altering the regimen to be more consistent to the way we should be using ER and LA opioids in comparison to some of the
Welcome to Select Communications. Enter your conference code, followed by the pound or hash sign. Thank you. If you are the leader, press star now. You will now be placed into conference. To mute your line, press star 6. To unmute, press pound 6. The leader has muted all lines. You will now be joined to the conference muted. To unmute your line, press pound 6.
To our practice on high doses of opioids, patients that have polypharmacy, patients with risk factors for overdose, and rethinking how to manage their pain through medication therapy management and other modifications to their analgesic regimen. Through the Gen Center for Primary Care, I serve as a advanced practitioner, so I do have prescriptive authority. I'm credentialed in the hospital like a mid-level practitioner so that I am able to see patients for evaluation, triage them, who are the patients that we can manage in primary care versus who are those patients that we need to refer to the pain management center. And in those patients where we are able to manage them in primary care, I'm authorized to initiate, modify, or discontinue any analgesic therapy that might be associated with their chronic pain. And I do that specifically for patients that are referred with a diagnosis of chronic low back pain, neuropathic pain, and fibromyalgia. So as a pharmacist, I think I provide a unique perspective to the team to be able to think about the patient in terms of choosing analgesic therapy, think about drug interactions and dosage levels and long-term impact of continuing opioids in patients with chronic pain. And I think that has allowed our team to be very successful in managing these patients safely and effectively. So I think the things that have been identified through the Department of Health and Human Services that are specifically related to identifying where these medications fit in, related to their efficacy and safety, is utilizing them at high doses for long-term therapy. We have data to say that that might not be the best for our patients. So that's something that we can do at an individual institution or nationwide to better rethink where these medications fit in, particularly at the doses and the durations that they're currently prescribed. I think we need to pay more attention to the co-prescribing of opioids with CNS depressants, particularly benzodiazepines. So that's something else that can be evaluated within a practice and maybe provide some education and referrals for patients so that there can be a reevaluation of what role either the opioid or the benzodiazepine, as an example, plays in that patient's care. The role of toxicology screening is still not clear to us in terms of how effective it is, in terms of the frequency. So that's something else that I think can be very valuable in evaluating the role that plays, especially because some of these tools, although they may be non-invasive for the patient, they can be very costly. The role of prescription monitoring programs, while they're a great tool for us to have on demand while we're prescribing or at the level of the pharmacy, we don't really have a clear picture of what impact they have overall on the landscape of pain and how that might change prescribing patterns or how that might also affect opioid-related adverse events. And I think one of the things that's most important that is missing significantly in the setting of chronic pain is paying attention to the mental health and the psychosocial assessment. I think that's really where the transdisciplinary team becomes important. So not just having physicians, nurses, pharmacists, but taking it a step further, social work, health coaches, any additional support that patients can have. So I think one of the things that we can evaluate is, are we doing the right psychosocial assessment in this population? Are we making sure that we're not managing emotional and psychological pain with opioids? Okay. And the last slide that I have is basically just kind of wrapping up and putting this into perspective from thinking about the fact that we have this new information, this new guideline that gives us some sort of different way to think about how we approach opioids with chronic pain, but there's limitations in the guideline itself. And when it comes to pain in general, it is never straightforward. In many cases, it tends to be more of an art than it is a science. So I think at the end of the day, we have to think about treating the patient, not the numbers, recognizing the limitations of the available evidence that we have, learning how to say no, because one of the hardest things is having a patient in front of you who's visibly suffering and demanding medication because they feel it's their right to have access to it, that you should feel supported by thinking about opioids in this systematic way, that it's probably okay to say no, and that these are all the options that you can present to the patient that are going to help support in managing their pain and getting them to their functional goals. And I think the last thing, because I know I cannot do my job by myself, I am so grateful to work as part of the team, because these patients require a lot of time. There's a lot of heartache and a lot of emotional impact that goes along not only with the patient but caring for these patients. So I think being collaborative, having that transdisciplinary team is the best way to move forward with ensuring that you can meet those quality outcomes. So with that, I am going to turn it over to Morgan, and I believe we're going to start taking your questions. And thank you all so much for participating.
Thank you, Michele. So we are ready for some questions. You can either submit them via chat or, even better, open your phone line to share. Morgan, can you let the participants know how to open their phone lines? And while we wait for that, I would like to start off with one question for you, Michele, and that is, I loved your talk and some of the challenges I think that we've seen in our med safety work is the fact that there's not a lot of data collection and measuring done around med safety. And I really liked the measures that you pointed out that you're looking at in your practice. And I guess my question is, are you actually tracking those measures and looking at baseline and trends? Before you answer, I'm going to let Morgan tell our group, our participants, how they can ask some questions via phone. So, Morgan?
Yeah, if you have a question, you can press #6 to unmute your line. We just want to give people a couple minutes to find the right buttons. Again, it's #6. And Michele, if you want to go ahead and answer Margie's questions while people try to get unmuted, that'd be great.
Sure. Yeah. So I have found that over time that a lot of the tools that I shared with you, the brief pain inventory, the PEG scale, which is actually the scale that's encouraged to be utilized through the CDC guidelines, that I find that they don't all individually meet the needs of my patient population. So I've actually created my own tool. It's not validated. I'm happy to share it with everyone. But what I found that it's a great way to track the outcomes that are most important to our patients. So some of it is focusing on pain severity. I think it's just helpful to have that documented, but it's looking more so at interference with mood, interference with sleep, interference with general activity, but then also commenting on where the patient feels do they feel that they're actually getting the right amount of pain relief from what we're doing for them, but then also satisfaction. So I'm happy to provide that to anybody that's interested. The one tool that was helpful, one outcome that was helpful for me in justifying integrating my services into practice was looking at the utilization of healthcare services by these patients before being referred to my service. So in the Gen Center, specifically the primary care department, patients were utilizing the emergency department or urgent care department on average about 5 to 6 times per year. And after referral to my practice, we were able to cut that number by 75%. And I don't think that it was anything magical that I was doing in managing these patients. I think what it was is that the patients finally had someone that they can dedicate to just focusing on their chronic pain. So I think it was that support, that following that patient over time, knowing that there was one person dedicated to communicating with them or to them about some of the concerns or issues they were having with their chronic pain. So, and obviously from a financial standpoint, you can tie money to reduction in emergency department visits and urgent care visits that are related to chronic pain.
Thank you so much, Michele.
Is anyone on the line? Again, it's #6 to unmute your line to ask a question. Doesn't seem like we have any questions at this time.
Okay, then I'll ask another question. Again, from some of the work that we've been doing in med safety, we've seen that it's really challenging to change prescribing habits. And even when you do some education, having pharmacists educate prescribers on appropriate dosing and prescribing, there still seems to be some challenges. Are you experiencing any of that, Michele? Are we seeing a change in prescriber habits over time and with the emphasis put on the opioid crisis?
So interestingly, and I think this is a result of there being more education at the level of medical school and pharmacy school, which I know was a big push for us here in Massachusetts as well. I worked with a group of junior residents recently, and the talk was specifically on opioids for chronic pain. And across the board, they were all pretty much, I'm not ever going to use these medications for chronic pain. Whereas going back about 5 to 6 years prior to that, working with the same group that was coming through our clinic, they were very much so open to kind of thinking about using them, but thinking more about where the risk assessment piece fits in and how to monitor and manage these patients, and will they have the right resources to do so. So I think that there's been a huge shift, and I think that I'm concerned about that because I want to make sure that there's still access to care for those patients that need it. But I also think that there's this new generation of prescribers that is up and coming where there's been more education about addiction and more education about opioids that has impacted how they are going to progress into their own clinical practice. Working with the providers that have already been managing chronic pain, and I'll just use my practice as an example, we've recently started to integrate more of this monitoring that extends beyond what I'm able to do because I have a limited capacity for patients. And what those providers are doing now is doing more of these random urine drug tests and ensuring that there's more risk assessment and management that's happening. And we are finding that prescribers who have previously thought that patients were doing fine, they're now identifying some concerning things, like we're prescribing oxycodone, yet the urine drug test is coming back positive for fentanyl. And why is that happening? So there are things that I think are forcing the providers to rethink how they prescribe, but I think that they're probably not going to change much, mostly because they can't until they get the right resources in place. So utilizing some of these transdisciplinary members, so pharmacists, nurse practitioners, physician's assistants, social work, and things like that, that can help provide that additional support to them. I think in those cases they are more open to not completely shifting away from using opioids, but again, reinforcing the role of individualized treatment.
Thanks, Michele. Colleen, I think we have some questions in chat.
Yeah, so I see somebody posted the Pain Disability Index. That's also an excellent tool to use for evaluating baseline ability to perform activities of daily living. That is another thing that I've integrated into this tool that I've created, but it's a nice way to document how that has been improved or not changed after therapy has been initiated.
This is Colleen. Can you hear me okay? Yes, we can.
Yes, thanks.
Great. So Gwendolyn asked, she has a patient who has returned home from the nursing home who's now worried about her scripts for opioids as she's in the community now and no longer exempt from the new rules in place regarding prescribing medications and reimbursement for patients on main care. She wants to know if this is happening elsewhere and if anyone has ideas.
So I know that Maine has gone through several regulatory changes as of 2017, also placing limits on the maximum number of milligrams of morphine equivalents that can be prescribed, with I think only a few exemptions to that. I'm not familiar with the prescribing practices and other changes, so I don't know that I can comment on that. But I think this was the concern about having guidelines such as this be developed and then promoted by a government agency, because yes, we expect the prescribers to pay more attention to where opioids fit in, but the fallout from this was also how does that impact the way that certain other entities, such as insurance companies, may affect coverage of these medications. So I know here in Massachusetts, every day I'm getting a new denial and new changes to formularies that are impacting access to opioids.
Thank you. We have a question from Alejandro who wants to know, are you experiencing pushback from patients not wanting to taper doses, and how do you handle them?
So I think we can do a whole other webinar on having difficult conversations in the setting of chronic pain. It's not easy, and I think there ends up a lot of the time being bargaining, which I don't think is always a valuable tool, but I think patients have to understand that by tapering or discontinuing, it doesn't mean abandonment. It doesn't mean that we're not going to help you any further, and I think that's what happens a lot of the times. And I think we get to the point of having a conversation about justifying why we feel it's necessary. And if we've had a good relationship with that patient and we approach their care, in this way that we've been saying that opioids are a trial, that we shouldn't end up being in this contentious conversation when that time does come. So it's never easy, but I think that if we approach the care of the patient the right way by thinking and making sure that we're selecting the right patient and educating the patient that if we're starting this, it means a trial. It doesn't mean that once we start it, you're locked in. That if I identify or you identify that there's some sort of concerning adverse event or behavior related to the use, it's at that point that we're going to start to step away from them. Some of this can be reinforced through the use of an opioid treatment agreement, so that everything is kind of laid out for the patient in terms of what's expected of us as the provider in terms of managing their pain, but also what's expected in terms of them related to our prescribing policies within the practice.
Thank you, Michele. I think it's time to wrap this up. As you can see, we have a schedule. We've just posted a schedule of our upcoming webinars. So to tie into what we learned today about managing the clinical aspects of patients on opioids, our next webinar, which is scheduled for January 24th, will discuss the prescription drug monitoring program as a tool to help us with our efforts in our different practice settings. So please save the date and join us for that talk. And for those pharmacists who are using this for ACPE credit, the code is TGMP, and to obtain your credits, you must complete the session evaluation. For non-pharmacists who complete the evaluation and enter the code, we will email you a certificate of completion. Posted now, you'll see all of the different contacts in the varying states. So if anybody wants to reach out to our med safety leads in the state, please use this information. And again, I want to thank you for attending, and I'm going to turn this back over to Morgan.
Thank you, everyone. As Margie just mentioned, the evaluation. When you close out of the webinar today, the eval will automatically pop up on your computer. If you could fill that out and get it back to, it automatically comes back to us. We would greatly appreciate it. If you don't have time to fill it out right now, or you're sharing your computer with someone, you will receive an email tomorrow morning that will include the link to the evaluation, so you can complete it at that time. As we mentioned at the beginning, the PowerPoint is posted on our website, and within the next few business days, a recording and transcript will also be added. The New England QIN-QIO is now on social media. You can find us on Facebook and LinkedIn, so be sure to check us out there. And as Margie had mentioned, our next webinar is on January 24th, so be on the lookout for emails about that and to register. And thanks again, Michele, for a great presentation. And we will review the chat log and make sure any outstanding questions get addressed and follow up with you all. So thanks again, and have a great afternoon.
Thanks, everyone. Take care.
Bye, Michele. Thank you.
The leader has disconnected. The conference will be terminated in 5 minutes.